Thank you for inviting me to talk about pediatric trauma for the trauma team training course. Doctors Cameron and I are both at McMaster Children's Hospital. I'm the pediatric surgery fellow, and he's an experienced staff surgeon. We thought it was important to add a pediatric component to the trauma team training program, as there is a significant volume of pediatric trauma, and there are some nuances to care for children that we thought was important to hide. First of all, injury patterns are a little bit different in children. They're more prone to multi-trauma. The most common source of injury is being struck by a vehicle. They all present with limb fractures or high risk of limb fractures, and head and neck injuries are common at higher speeds. Other mechanisms include fall from a bicycle, fall from a structure, and motor vehicle collisions. Children have a smaller surface area, which means the force from a blunt trauma is distributed over a smaller area, resulting in higher rates of multi-system trauma. Additionally, if a child is under 12 months of age, the chance that they're presenting with trauma secondary to child abuse is significantly higher. Airway management is a little bit different. Their large head means that when they're laying flat on their back, their neck is actually flexed forward. By placing a blanket or a bolster under their shoulder, you can open their airway and improve access for intubation if needed, or just allowing them to breathe on their own. There's a few differences between children and adults in terms of their airway management. They're listed there. But when intubating, it's important to remember that because of their long and floppy epiglottis, you actually grab the epiglottis and pull it forward, as opposed to placing it anterior, the laryngoscope anterior to the epiglottis in adults. Targeted respiratory rate is dependent on the age of the child, and emergency airway management is a little bit different, with a needle cricothyrotomy preferred over surgical cric in children under 10. Vital signs vary with age, and it hadn't been highlighted anywhere else in the program. We thought it was important to have something that was simply laid out like this for reference, and we wanted to point out that hypoxia is more likely in children because of their lower lung capacity and higher oxygen consumption. For pediatric resuscitation, you should start with 20 mL per kilo bolus of crystalloid, and then move to blood if they don't stabilize and there is blood available. You can then target your resuscitation based on urine output, and urine output varies with age, with 1 to 2 milliliters per kilogram per hour for infants, and going down to 30 mL per hour for teenagers who are over 30 kilos. Burn resuscitation should use urine output once the initial resuscitation has started, and it's going to be dependent on the child's age. Calculating body surface area is also different because of a child's different body proportions. It'll vary with age based on the changing size of their head, torso, and limbs. And you can see on the right-hand side there's a diagram that can be referenced. Thoracic and abdominal trauma is common, particularly with higher force blunt traumas. Their mediastinal mobility means attention pneumothorax is more common in adults, but things such as flailed chest, diaphragm disruption, and so forth are more rare in children. Abdominal trauma can be a little challenging to assess, and it's important to remember that gastric and urinary bladder distension can lead to abdominal distension and pain, so decompressing those is important before declaring there's an acute abdomen. Lap belt and handlebar injuries are also important to look for, and bladder rupture is more common in children because of their more shallow pelvis. For solid organ injury, remember that children's bones are incompletely calcified, so lack of rib fractures overlying the rib or spleen cannot rule out solid organ injury. Non-operative management, though, is used for most kids, and if they're hemodynamically stable or if they stabilize. If pediatric surgery is not available, transfer to a facility that can provide that service should be done if it's safe, though laparotomy might be the appropriate intervention if they cannot be stabilized. A FAST scan, or focused abdominal sonography in trauma, it hasn't been mentioned elsewhere in the course, and increasingly ultrasound is becoming available in smaller hospitals in developing countries and is an advanced imaging modality that may better be able to triage patients based on their cardiac, thoracic, and abdominal ultrasound findings. But it's important to remember that a fast scan rules in injuries but does not rule out injuries. Head injury is a common issue because of the child's larger head and the increased forces movement of that head will experience and the decreased volume of fluid within the skull. Fontanelles do allow for greater tolerance of intracranial blood in infants, and keep in mind that a bulging fontanelle should trigger concern for a serious intracranial injury. The key, however, to blunt traumatic brain injury is adequate resuscitation to restore cerebral perfusion. Head injury assessment is more challenging in children, especially without cross-sectional imaging, but a GCS of under 13 in the absence of intoxicants should be concerning for a significant head injury. Skull x-rays may be helpful, but is not a definitive test. Spine injury can also be challenging to assess because x-rays may find subluxation of the cervical spine, and non-bony injuries are more common in children. However, subluxation may also be a normal finding, and to differentiate, you can actually you can re-x-ray after repositioning the child as described there. Child abuse is also a major problem that has not been addressed elsewhere in this course that I think is very important to bring up because the abuse rates are incredibly high and concerningly are overlooked in most courses. I invite your feedback and comments and thank you for your time.